I'm actually moderating this conversation today, and I'd like to introduce you to my fellow esteemed panelists, Dr. Mahoney, who is the Chief of Staff at Stanford Healthcare and Clinical Professor in the Department of Medicine at Stanford University. Dr. Jehan Bayoumi is the Founding Director of the Rodham Institute at George Washington University School of Medicine and Health Scientists. And then we also have Reverend Lamar, who is the pastor of Metropolitan African Methodist Episcopal Church in Washington, D.C. Though the impact of medical racism and structural racism stretches far beyond Black Americans, it's really important that we ground this discussion in the theme of the Real Health Equity Summit, which is about changing out loud, and in some ways addressing the elephants in the room, right, for us to drive change. And I'm sure that we are all more than familiar with Harriet Washington's research in her book, Medical Apartheid. It vividly contextualizes the deeply rooted, justifiable distrust in systems that intentionally and historically excluded those whose humanity was invalidated by the same systems which were not originally meant to help and heal them, us, in the first place. But toward the very end of the book, Washington writes that today, much medical research is more than safe for African Americans. It's necessary. And her point was that the fear and distrust that is the direct outcome of Black bodies only having labored utility were more than valid, and they continue to be more than valid, right? And that we must acknowledge the past in order to regain trust and to seize the future. So that's where I'd like to start our conversation today. So my first question is not going to be about trust, it's going to be about trustworthiness. So to improve trustworthiness in and the relevance of our collective efforts to advance health equity, when it comes to the role of providers, what does it look like to change out loud? I will ask Dr. Mahoney to get us started.
Well, thank you, Jewel, and thank you all for joining today. I'm looking forward to the interaction. We have a wonderful panel here. It's an incredible privilege to be a part of this esteemed panel. So I do appreciate the quotes from Medical Apartheid. That was a difficult book for me to read, to acknowledge that I have been part of an institution that has this legacy and this history. And I'm excited at the same time to start defining a new future for all of us collectively. And it really does start with reflecting on our past and looking at ways in which we are accountable and need to build that trustworthiness. It really is the most essential part of what we can do in medicine. So what I would like to share is that I'm seeing that I'm not alone, that there are a number of us in the medical field that are very eager and hungry for this change, for real structural changes to happen. And it's not only because we know it's the right thing to do, we also are responding to our patients. And the COVID pandemic in particular has affected our patients' ability to trust the care that they're accessing. In a recent survey by West Health and a Gallup poll, I was looking at the percentage of Americans who do not feel comfortable accessing care. They don't feel like they're getting the value they need. Over half of the Americans feel some level of discomfort with the care that they're receiving. And that's a problem. We need to change that. And I'm eager to jump into a conversation about structural changes that need to take place to respond to our increasingly diverse patient population. So thank you for having me.
Great. Dr. Gigi, I see that there's something on your mind. I can just tell you're eager to jump in.
Well, thank you. There's always something on my mind. So thank you, Ms. Jewel, and good afternoon, everybody. I think that it's important to not just talk about historical, but ongoing racism, classism, and sexism. Of course, the country and how actually universities were established, especially Ivy Leagues, universities were actually on the backs of Black people. And if you want to read just an excellent book, well, there are so many, but I just slipped my mind. But one of the books is If They Were Her Property out of Berkeley, actually, California. I'll get the books and share them in a second. But I want to talk about sort of my frustration with the latest DEI, microaggressions, health equity. It's really talking around the margins and not really looking at the specific issues. We have a crisis. The fact that we have worse outcomes right now in COVID and continue to see more Black and brown and indigenous peoples dying from COVID, and same with the children, that's a crisis right now. We cannot afford to do in-depth studies because there's a lot of studies that are out there. The time for action is now. So what does that look like? First of all, let's admit that there is a very strong class two-tiered system within our institutions. The way that mostly Black people who run the hospital, be they the staff, be they the people that bring the food, be they people that stock the shelves, whatever it is that are crucial to running our healthcare system, which actually comprises about 80% of the workforce, get treated in a horrible manner. I can tell you that 1 in 5 of the medical assistants that I work alongside with, and please visit the Rodham Institute website so you can see the studies that we've done or commissioned, 1 in 5 are getting government assistance. 1 in 5. I have a woman that I work right alongside with who works at McDonald's to make ends meet. That is pathetic. If we really care about providing good care and equitable care, we need to hold up a mirror to ourselves. There are colleagues, faculty that I like that never acknowledge the people that we work with. If that's not racism, classism, et cetera, I don't know what is. Furthermore, I can tell you that especially there are Black women that can run the institution where I work, and yet the people who keep getting promoted may have some letters behind their names, but are, I'm sorry, incompetent oftentimes. And so what equity looks like is really being consistent at every single level. And of course, when you do that, everything is going to be reflected. That approach will be reflected in patient care. I got more to say, but I'll stop.
So, Pastor Lamar, I certainly see that there's something on your mind. And I'll just say, as someone who doesn't just experience the healthcare system as a patient and as an individual, you spend a lot of time, right, going in and out of, out of the hospital system as you accompany your congregants, the work that you all do from a community-driven perspective, a justice and community-driven perspective that's focused on equity, justice, and liberation. So really kind of curious to hear your perspective on this issue and this topic of that we have today.
So I want to begin with a theological framing, and that is, in my opinion, in our tradition, the Creator made us and made all that human beings might share abundance and we might flourish together. So health, physical health, communal health is you cannot separate that from shared abundance and human thriving. So I like this language of rootedness, and I think we must remind ourselves or learn for the first time that the structural racism that we see, racism in America, cannot be intertwined. It cannot be distinguished from, rather, capitalism. Capitalism, structural racism, white supremacy, anti-Blackness are tied together. From the 50,000-foot view, because I know that there are people watching who are venture capitalists who are trying to figure out how we do a better job of this. I, as a pastor, I want to encourage us. We must take the capitalist logic out of the healthcare system.
Mm-hmm.
be profit driven. We have to have new ways of considering economics and investments, because what I see from my parishioners and people in the community, you cannot access health without money. So Dr. Gigi just shared the difference in the life expectancy between people who live in Georgetown and people who live in Ward 8. The people in Ward 8 are no less human, but they do not have access to the wealth. And they don't have access to the wealth because of structures and systems. And if we do not use our imaginations and creativity to discover new ways to share health and new ways to share scientific advancement with all human beings. You know, if you look at what the pandemic teaches us, it teaches us that viruses don't care, right? They don't care who you are or what you have. And if you have a group of people who are suffering, who are poor, who don't have access to the best medical care, then their lack of health affects all of us. And so the connectedness must be lifted up. And I really want to encourage us. We don't do work around health, be it physical or spiritual health, with a profit motive. We have a vision of community, a vision of human flourishing. And I believe that the people listening today resonate with what we're saying, and we can imagine something new. Something new is possible. What we're doing definitely isn't working.
Mm. So to that point, what or who is missing from the current discussion about, the role that providers play in addressing structural racism, social determinants of health, and all the other issues that create the inequities and injustices? And, what has become too much of a focus or a distraction in the conversation about this?
I can tell you that, we have the Anti-Racism Coalition at GW, and a lot of the discussion is about microaggressions that are focused on medical students and faculty. As somebody who's faced micro and macroaggressions, that's an important issue, but we're not getting down to the issues that I had alluded to before. So people that are not at the table are the, non-MD, especially non-nursing. People that are not at the table are our patients or our communities. So there are key, stakeholders that are not there. And the people that are the closest to the problem drive and understand the solutions, but may not have the resources. So the way that I look at us, as especially in academic medicine, we are consultants. We really serve at the pleasure of the community. They know best. And we are here to help facilitate, accelerate, and catalyze.
Yeah, I just wanted to build off of that comment that we really do need to break down some silos. And as a provider, as someone who's been in academic medicine my whole career, I can't say enough about getting outside of the ivory towers to learn about where health and illness really is impacted. It's not within the hospitals or the clinic walls. It's happening out in the community. And I'll just share a couple of examples. I served as a provider in the California state prisons. California has the unwelcome record of having the largest prison system in the country and the largest women's prison system in the world, and that's where I worked. And I worked in solitary confinement with a transgender woman, and she was only able to go out into daylight, 1 hour a day. And seeing her experience as a transgender woman in this large women's facility was eye-opening for me as a provider. I was able to see where health was really happening, how incarceration and recidivism and our prison and industrial complex is affecting society in a way that I could read about in a textbook and I could go to a medical school class about it, but to go and see it in real life, or even getting outside of our country, going to, I spent 2 years in Nairobi, Kenya. And I have to say that, Reverend Lamar, the comment you had about how do we partner with the community in an innovative way I learned how they were doing it. It wasn't a profit motive at all. It was about I wasn't able to even engage with the community until I went to the chiefs, the village chiefs, and I engaged with church leaders. And so bringing some of these things that we know are effective in other places, bringing them back, community health workers being a great example, so that we can have real experiences and understand what the we call it social determinants of health, what those are, and bring them into medicine, so we can really practice real medicine and really provide real health and real health care. So those are my perspectives.
I just remember the name of the book. It's called Ebony and Ivy is the name of the book.
Yeah.
Okay.
It's a great book, Dr. G. It's a great book. No, not at all. So what I was going to say, not only must we envision a new way of conceiving our work economically, but I think that we are entirely too self-congratulatory. So you go to a couple of DEI classes and you take some microaggression stuff and you shake hands with somebody who's of a different color and you got the picture. There's a deeper reality. Let me tell you what I have experienced as a pastor and someone moving about in the community. As Dr. Gigi has said, normally what you have in the room are people who think they are called to make decisions for others. But the people who are not in the room carry the wisdom. And so here's the issue, though. I've been in rooms where we bring those persons in, the excluded, but they are not treated well. Their stories are not valued because the leaders in the room do not value their humanity. They see these people as problems. So I go back to Du Bois and his Souls of Black Folk, where he said, he's reading and someone's asking him, how does it feel to be a problem? Well, he's not the problem. The structures were created to extract from him and not to allow him to flourish with the gifts that he brings. So what I would say to many of us, we've got to learn how to listen to the wisdom and the knowledge that these persons have, though they may not have a certain educational attainment, their wisdom and ability to navigate the very cruel economic reality that is the early 21st century American empire is tough, and they navigate it. They find ways to survive. And if their wisdom and knowledge leavens the loaf of what it is that practitioners and researchers and leaders are doing, their voices are missing, and that costs us as far as the health of the community. So how can we have different kinds of conversations, building real relationships across the divides? That also will help as we envision new structures and new possibilities.
And if I could just add, even from an economic standpoint, we have the most expensive system in the world, and yet we're number 37th. One of the reasons that the big three, and I'm from Michigan, automakers failed is when you look at Japanese, car manufacturers at the time of 2008, they spent about $400 per car on health insurance for the workers. We were spending $1,400. So even if you're looking at it from an economic standpoint, it doesn't make sense. But I want to add something to you, because I don't want this to come off as me judging. Okay, we are the enemy. We have seen the enemy. The enemy is us. So for 20 years, I was in charge of educating medical students and residents. And I always tried to kind of forestall or mitigate the jading process that I would see, where at the very end of their training, they would objectify the very people on whose backs they've trained. And this is what I've come up with. I said, we are teaching racism, classism, and sexism. Let me give you an example. If you have two women, both with pneumonia, one is a college professor, another one is homeless, she's HIV positive, she's in the middle of a psychotic break with her schizophrenia. Who is easier to take care of? Of course, the college professor. We speak the same language. If I tell her, professor, you need to refrigerate the antibiotics, you need to take them with food, and if there's a problem, call us back. And if she can't get in through the phone system, which is dysfunctional where I work, she can call her friend and say, you know somebody at the medical school, how do I do that? The other lady, first of all, we can't understand her. She's disorganized. When we are trying to give care to her, look what we do to our learners in terms of putting them in bad situations. It's below zero, with the wind chill, it's 0 degrees outside. There is only one shelter that takes people who have any medical problems. The administration says, you got to discharge, you got to discharge. You're going to discharge them to the street. What is that doing in terms of the morals and the ethics of that person? Furthermore, in the hospital, because I work both in the hospital and the clinic, there aren't those systems that really can help support that lady, right? So everything gets put to the intern or the medical student. But here's a solution to combat that. We need to know where people live. We actually have a program called See the City You Serve. We need to see people when they're not sick. I mean, I don't know about you. When you've been sick, I can tell you my hair is all screwed up. I look awful. That's not how I want to present myself. I'd rather present myself in a more sort of equal footing. So there are things that we can do. And there are systems, as Dr. Megan has pointed out, I'm also of African origin, that have worked and are much better than us. And humility, I think, to your point, Reverend, is so important for all of us.
Dr. Gigi, can I build on the point that you just made about how we show up, especially in community, in the comfort of our own homes, and in healthcare systems and spaces? You know, as you guys were just talking, it brought me back to a thought about my great grandmother who passed away when she was 92 years old. So I spent a lovely, few years getting to know her and spend part of my life with her. And I will never forget, one of the clearest memories for me is how my great grandmother, who was born in the early 1900s, how she dressed when she went to the doctor's office. Mm. She got dressed to go to the doctor's office, and I didn't have the words for it then, but now I do. And I know that it was about respect, humanity, and dignity, right? She, some of us might call a portion of that Black respectability, but what she was doing was she wanted to make sure that this woman born in 1902 in Virginia, right? In Virginia, she wanted to make sure that when she went into healthcare spaces, she was seen as neat and well poised and well put together, and so that they would see her as human. I can't help but to wonder, based on what you've just said, and the fact that all of us have biases, right? If we could only focus on 2 or 3 things about the role providers play in addressing structural racism, what do you think would be most impactful in 5 or 10 years? Because at the end of the day, I've adopted some of those same habits, right, that I saw. And I do the same thing with my kids and my family. But I would love the freedom to feel like I needed to walk into a doctor's appointment or into the healthcare system looking as I do when I go to work, right? And there's a privilege in that. So, what would you say are the 2 or 3 things that we could do to improve the role of providers in addressing issues related to structural racism that would have an impact in 5 or 10 years?
Okay, I'll get us started. Jewel, thank you so much for sharing that story about your great-grandmother. She reminds me of one of my favorite, the description reminds me of one of my favorite patients who's actually from the Midwest, but she moved out recently to be with her daughter. She's a little bit younger, so she's 86 now, and we'll call her Ruby. I'll just use that name. But when I first met her, she did talk about some of her previous healthcare experiences and how she felt like the physicians were talking down to her. They weren't listening to her. She was just really polished. The way she dressed was very, the way she came across. She really wanted to convey respect and dignity, and yet her experience was not living up to what she was bringing to the table. And so I was happy to be able to work with her. And one of the things that we were focusing on was hypertension. We were interested in measuring her hypertension outside of the walls of the clinic and engage her in the digital health revolution. An 86-year-old African-American woman, we hear about the digital divide and, it turns out she was able to engage. She was like our favorite patient as far as that's concerned, so engaged, entering her data. It did take a little while. She and I work with a medical assistant, work with a health coach, and then also with her daughter. But she was able to get on the technology and do it. So I think that when you're asking about two things that I would focus on, I would want to ensure that we're doing our part. She's showing up. How are we showing up? Are we doing our part to overcome any digital engagement issues that could be there? Are we showing up as far as our bias? Are we really addressing that in our healthcare system? Are we eliminating the ways in which racism persists in the way that we're practicing medicine? One I've talked a lot about previously being the use of race in our calculators that we use to determine who should be on blood pressure cholesterol lowering medication, and then and kidney disease function calculations. Really eliminate. We are there to show up for our side of it as well. And then the second structural change that I would say is really important is to address the rising costs of care. I know that we have all been talking about this, but increasingly this is affecting communities of color, and people are more and more reluctant about accessing care because of the cost and the risk that they face of receiving a bill that could be devastating. And we're seeing that more and more because of the pandemic. And so that's something that we'll need to face going forward.
I think that providers live frenetic lives, and probably to hear people like us saying, need to do one more thing is probably like, oh my God. But part of what I want to encourage one, keep the imagination alive that the system that we have, and to use the words of Ron Heifetz, is not broken. It was designed this way.
Exactly.
And is profiting and growing powerful off of a system that is producing this inequality and really dealing death according to race and income/class. So you have to imagine the new reality economically and the new outcomes and move into that creatively. I think number two, in the healing tradition, I see you all as healers. The healer lived amidst the people in the community. We have to find ways that those still practicing the healing arts are in the midst of community. How you build relationships and learn, where you subvert the reality that you are always teacher and never student, but you assume the posture of student and learner. And I think finally, there are so many ways for you to use your voice and to speak up, because we know the majority of Americans want a universal health care, right? But the way that our system is set up with the way that the Senate is designed, which is radically undemocratic, where a state like California has 2 senators and a state like South Dakota has 2 senators, right? So the people are not being represented as they ought. So engaging in that way with the political realities that can get us closer to shared flourishing and human abundance.
So I would like to remind everybody that what we do as clinicians or the healthcare system only accounts for 20% of all outcomes, right? We've alluded to social determinants of health and structural determinants of health. I will just tell you that of all the factors that impact mental health, food is before even housing. So I think, first of all, educating ourselves of why it is that the economic health of a neighborhood is important. You know, backstage before we came on, I talked about in DC, people who live in Georgetown, they have a 94-year life expectancy on average. People who live in Ward 8, it's 66 and a half years. If I, as a physician, all I did was to get kids to graduate from high school, I would add 10 years of life. Right now, there's only 42% of kids that graduate from Ward 8 in high school. But what I would say is this. People talk about cultural competency as though we need to learn every little, culture and subculture of all the peoples in the world. No, we lead by being human. When I used to orient the residents, I would say, pretend that this is your mother, father, sister, brother, aunt, uncle, or grandparent. Be human. And guess what? Pastor, you talked about the frenetic lives. When you behave that way, that actually immunizes you against burnout, us. So this sort of directional learning is not just for the benefit of the people we serve. It's actually, I always say, I get more. So that's one. Be consistent in your behavior is number two. It's important that we know the names of the people that we see every day. It's important that we know that, oh my goodness, so-and-so's child is struggling with cutting themselves. Okay. Or, so-and-so's grandmother has died. So I couldn't agree more about the profit motive and how we really have to, there's so many ways that we as clinicians can make our voices heard. But what we also don't want to do is we don't want to re-traumatize people that come from communities, whatever those communities are, right? Because we tend to forget about minorities within minorities, like disabled people who live in Anacostia, or blind or deaf people or shut-ins. So that when a woman who's overweight, and I'll give you a specific example, one of the residents comes in and says, I have a lady, African-American woman, I lectured her for half an hour about why she needs to lose weight. I said, but it says here that she's coming here because she may have had a mini stroke in the emergency department. I walk into the room and the lady is just sitting like this. And of course, I said, tell me what happened. So these ideas that, that we know better, the point that Dr. Megan made about listening, just listen. And believe it or not, although I'm a talker, I do listen. But I think it's important that we examine what we do on an everyday basis, every day with everybody that we interact with, and that everybody has value and is important.
Great. Well, I know we only have a few minutes left, so I would love to do a very quick lightning round to hear from everyone. Just one last question. What does success look like to you when it comes to ensuring that providers are leveraging their seat to improve health outcomes for all? And I know that we have Dr. Aletha Maybank, the Chief Health Equity Officer for the American Medical Association, joining us tomorrow. And, they're doing a lot of great work, but would love to hear from each of you, what does success look like? If Pastor Lamar, if we were to reimagine, right, what does that look like very clearly and very tangibly as a last thought for those who are joining us for today's conversation?
I think systemically, it looks like universal health care. All of us share an excellent standard of healthcare, no matter what our zip code. And I think it also means that we have to build human connections and relationships to tear down the stories we tell ourselves. So Dr. Gigi, whomever you were speaking with, when they saw that obese woman, they were telling themselves a story about her, which victimized her, made her a person who makes poor decisions, who's morally bankrupt, and absolutely none of that may be true. And so we've got to retrain the stories that we tell ourselves and provide everyone excellent care.
Great. Dr. Mahoney?
I think in the next 10 years, if we could produce a generation of healthcare professionals out of our medical schools and other professional educational schools, a generation of healers who are oriented towards promoting health, who have effective communication skills and listen and orient the plan around the patients and community's goals, that would be success for me.
Great. Dr. Gigi?
And for me, it's also about outcomes, that the gap that is in Washington, D.C. gets closed. But from the moment a human being comes to whatever healthcare system we're talking about, that there is a smile, that they're being treated with dignity, and more important, when they're leaving with a smile and feel like they've been listened to. And so, yeah, and everybody else that's working in the system. But that's what I would say.
Great. On that note, thank you, Dr. Gigi, Reverend Lamar, and Dr. Megan Mahoney for this important conversation. Thank you to everyone who attended.